everyone present over here. This is Bhumika Khulkar, roll number 66. Today, myself along with my batchmates will be presenting posterior pituitary and its Today, myself along with my batchmates will be presenting posterior pituitary. It's a crucial part of the endocrine system. While being small in size, its role in maintaining various physiological functions is very significant. Our presentation is divided into 10 sections, with each of us covering different aspects to provide a clear understanding of its structure, function, and of course, its clinical relevance. I'll be briefing you all about the posterior pituitary itself, and then we'll learn about its components in detail. One thing about posterior pituitary we all know is that posterior pituitary hormones are synthesized by the cell bodies in hypothalamus. The bodies of the cell that secrete the posterior pituitary hormones are not located in the pituitary gland but large neurons called magnocellular neurons located in the supraoptic and paraventricular nuclei of the hypothalamus. The nerve fibers are then transported in the axoplasm of the neurons, fibers passing from the hypothalamus to the posterior pituitary gland. Talking about the posterior pituitary gland, posterior pituitary and its relation to hypothalamus. Posterior pituitary is also called as neurohypophysis. It's mainly composed of glial-like cells called pituocytes. These cells do not secrete hormones but act like supporting cells for terminal nerve fibers and terminal nerve endings from nerve tracts that originate in the supraoptic and paraventricular nuclei of hypothalamus. These tracts pass to the posterior pituitary through pituitary stalk. The nerve endings are bulbous knobs that contain many secretory granules. These endings lie on the surface of capillaries where they secrete two posterior pituitary hormones, ADH and oxytocin, about which we will learn further ahead in the presentation. Let's discuss a fun fact. If the posterior pituitary stalk is cut above the pituitary gland, but the entire hypothalamus is intact, the posterior pituitary hormones continue to be secreted normally. This happens because hormones are initially synthesized in the cell bodies of supraoptic and paraventricular nuclei, as discussed before, and then are transported in combination with carrier proteins called neurophycins down to the nerve endings in the posterior pituitary gland. ADH, that is antidiuretic hormone, it is formed primarily in the supraoptic nuclei, and oxytocin is formed primarily in the paraventricular nuclei. Although each of these nuclei can synthesize about 1/6 as much of the second hormone as of its primary hormone. Talking about the hypothalamic control of the posterior pituitary. When nerve impulses are transmitted downwards along the fibers from supraoptic and or paraventricular nuclei, the hormone is immediately released from secretory granules in the nerve endings by usual secretory mechanism of exocytosis and is absorbed into the adjacent capillaries. Both the neurophysin and the hormone are secreted together, but because they are only loose bound to each other, the hormone separates almost immediately. The neurophysin has no known function after leaving the nerve terminals. Now, Razuka will be explaining about ADH.
So now as we know that the posterior pituitary secretes two hormones, so I will be dealing with the antidiuretic hormone. So here the word antidiuretic means any substance or in this case a hormone that decreases urine output and prevents diuresis. And This hormone is also known as vasopressin as it is a vasoconstrictor. So both the names of this hormone are derived from its two main functions. So now coming to synthesis. Images are again there. So the ADH is synthesized in supraoptic nuclei of hypothalamus, and then it is secreted down in the posterior pituitary and then released into the bloodstream so that it can reach to its target organs, that are blood vessels and kidneys. Now let's talk about the chemical composition of ADH. Chemical composition, ADH is a cyclic nonapeptide. That means in one molecule of ADH there are 9 amino acids and there is a sulfide linkage present between the sister residues 1 and 6. So the main part, the functions of ADH, so the main function is antidiuresis. So this ADH sends signal to the kidneys for reabsorbing more water from the collecting ducts and tubules, so that the urine output decreases, urine concentration increases, and hence the water is regulated in our body. For the interruption. So coming to the functions of ADH, the first function is the antidiuresis. So this ADH sends signal to the kidney for the reabsorption of water, and hence the urine output decreases and the urine concentration increases, and thus regulating the water balance in the body. So this is the actual antidiuresis mechanism. Whenever there is presence of ADH in the body, the collecting tubules and renal tubules permeability increases for the water, which leads to the significant reabsorption of water and its conservation. So the concentrated urine is produced. So now whenever there is absence of ADH in the body, these collecting tubules and renal tubules become less permeable for the water. So there is extreme loss of water from the urine, and hence it produces diuresis, which means the more urination. The collecting ducts present in our kidneys have tubular epithelial cells having the luminal membrane. Now this luminal membrane is almost impermeable to water without ADH. So we require ADH for the conservation of water. The next function is blood pressure regulation. Now since ADH is a vasoconstrictor, it constricts blood vessels and is involved in increasing blood pressure and blood volume. These are some of the other functions of ADH. First includes osmoregulation. ADH regulates the osmotic balance and water balance of our body. Second is the sodium homeostasis, which means that the ADH regulates the sodium balance by water excretion and its retention. And third is the neurological function. Now according to recent studies, the ADH receptors are known to be found in this our brain and central nervous system, which means that ADH might be involved in our memory formation and social behavior. So this is the mechanism of action of ADH. There are tubular epithelial cells in collecting ducts as previously said, which have aquaporins. Now these ADH combines with the membrane receptors and forms the cyclic AMP, that is cyclic adenosine monophosphate, a secondary messenger in this cell. Now then the phosphorylation of elements of aquaporins occurs, and thus the aquaporins provides high surface area for the reabsorption of water. Now this ADH is regulated by two mechanisms, which will be further discussed by Mohit and Ravina.
Good afternoon. My name is R.Bokare, roll number 63. My topic is regulation of osmolarity by antidiuretic hormone. Osmoreceptors are modified neuron receptors. Some researchers place the osmoreceptors in supraoptic nuclei of hypothalamus, while others place it in organomusculosum, which is a highly vascular structure present in the anterior ventral wall of third ventricle. Osmoreceptors rapidly respond to the changes in osmolarity of extracellular fluid, and it has a powerful control over secretion of ADH and over thirst. Factors affecting increase in osmolarity. First, dehydration. It can be caused due to insufficient fluid intake or excessive fluid loss. Second is electrolyte imbalance caused due to high sodium levels. hormonal imbalances, kidney damage, heart failure. Factors affecting decrease in osmolarity. It can be due to excessive fluid intake, electrolyte imbalances, hypothyroidism, kidney diseases, and due to syndrome of inappropriate antidiuretic hormone called SIADH. Now we will understand osmoreceptor antidiuretic hormone feedback system through a diagram. When there is increase in osmolarity in the blood due to water deficit, osmoreceptors in the hypothalamus will detect the increase in osmolarity. It will cause its shrinkage and decrease in size. It will cause the stimulation of the osmoreceptors and nerve signals will be produced. These nerve signals will be transmitted through the stalk of the pituitary to the posterior pituitary gland, where these nerve signals stimulate the ADH secretion through the secretory granules of the free nerve endings. This ADH will be then secreted into the blood. Through blood, it reaches kidney, where it acts on the V2 receptors, which causes increase in the permeability of the distal tubules, cortical collecting tubules, and medullary collecting ducts, which leads to increased reabsorption of water, which decreases osmolarity to normal. Now, decreased extracellular fluid osmolarity. When the water is conserved in the body while sodium and other solutes continue to excrete in the urine, it causes dilution of the solution in the extracellular fluid, thereby correcting the initial excessively concentrated extracellular fluid. Conversely, when extracellular fluid becomes dilute, for example, with excess water ingestion, decrease in extracellular fluid osmolarity leads to less ADH being formed. The renal tubules then decrease their permeability to the water, resulting in less water being reabsorbed and large volume of dilute urine being formed. This process in turn concentrates the body fluids and returns the osmolarity towards normal. Now, Ravina will continue.
Vasoconstrictor effect of ADH. Low blood volume and low blood pressure stimulates ADH secretion. Although minor concentration of ADH cause water reabsorption by the kidneys, higher concentration of ADH cause potent effect of vasoconstriction, thereby constricting the arteriole, thereby increasing the arterial pressure. Hence, ADH is also called vasopressive. Here in diagram, dehydration, blood loss, and low amount of water in the blood can cause blood volume and blood pressure decrease. Neurosecretory cell of the posterior pituitary secrete ADH. ADH binds to the smooth muscle in the blood vessel, constricting them to increase blood pressure. After that, blood pressure becomes normal. Hypovolemia is a more potent stimulant effect to release ADH than hyperosmolarity. This occurs mostly when the blood pressure decreases by 10 to 15% or more. The secretory rate then increases high as 50 times the normal. The atria has a stretch receptor which are stimulated when they are overfilling. When they are excited, they send signals to the brain to inhibit ADH secretion. Conversely, when receptors are unexcited due to underfilling, the opposite occurs with greatly increased ADH secretion. Decreased stretch of the baroreceptor of the carotid, aortic and pulmonary region also stimulate ADH secretion. Now in flow chart, low blood volume is present when there is detection of a water level by the receptor. So release of ADH from pituitary gland. Due to this increase in water reabsorption by the kidney, so low lost in water, so concentrated urine and maintenance of blood volume and osmolarity occurs. Now for the RN meter.
Good afternoon everyone, this is R.Bokare, roll number 68. Today I will be talking about the second hormone released by posterior pituitary, that is oxytocin. So oxytocin is a hormone which is produced by hypothalamus and which also plays a pituitary gland. It's a peptide hormone, neuropeptide to be precise. Now I will brief you about the chemical composition of oxytocin. Oxytocin is a neuropeptide which basically means that it has 9 amino acids in it. So the sequence of those 9 amino acids is cysteine, tyrosine, isoleucine, glutamine, asparagine, cysteine, proline, leucine, and glycine. It's a 6-member ring with a disulfide bridge and has 3 amino acid tail. So oxytocin mainly has 2 functions. First one is causes contraction of uterus towards end of gestation period. Oxytocin also helping milk ejection by the breast. Some sources say that a G protein coupled oxytocin receptor has been identified in myometrium and also in mammary tissue. As we have seen that oxytocin mainly has 2 functions. Now I will be explaining the first function, which is related to uterine contraction in detail. So the effect of oxytocin in uterus is different in pregnant and non-pregnant women. In case of non-pregnant woman, it facilitates the sperm transport. The passage of sperm in female genital tract to the uterine tube when fertilization normally takes place. The transport of sperm not only depends on the motile activity of sperm but also on uterine contractions. Now, in case of pregnant woman, the function of oxytocin is contraction of smooth muscle in uterus. After dilation of cervix, descent of fetus takes place, which in turn initiates sensory impulses from afferent nerve fibers to the supraoptic and paraventricular nuclei present in hypothalamus, which leads to secretion of sufficient amount of oxytocin. The second function is milk ejection by the breast. Oxytocin plays an important role in lactation. During lactation, oxytocin causes milk to be expelled from alveoli in the ducts of breast, which helps the baby in sucking of milk. This is actually done by milk ejection reflex. So in the given diagram, you can see that the mechanoreceptors are present in the breast. When baby sucks the milk, the stimulus are transmitted through the sensory nerve to the oxytocin neuron present in paraventricular and supraoptic nucleus, which leads to secretion of oxytocin, which is carried to breast by the blood, which ultimately causes contraction of myoepithelial cells, which leads to contraction of smooth muscle present in uterus, which leads to ejection of milk. This pathway is known as milk ejection reflex. So that was all from my side about the oxytocin. Further discussion will be continued by Ram.
Good afternoon to everyone. My name is R.Bokare and the roll number is 71. My topic is central diabetes insipidus. Central diabetes insipidus is a rare disorder which is caused due to ADH deficiency. ADH is also known as vasopressin. Its primary function is to regulate water balance and it acts on kidney by reabsorption of water. Central deficiency CDI is caused by head or brain injury. Second, infections, congenital causes, symptoms of central diabetic insipidus. The first one is excessive urination. In normal person, 1 to 1.5 urine is excreted per day, but in central diabetic patients, 10 to 20 liter urine is excreted per day. Second one is extreme thirst, even waking up at night to drink water. Third one is dehydration is seen in the CDI patients if fluid intake is insufficient. Fourth one is fatigue and irritability. Fifth one is low urine osmolality or dilute urine. Now, this is the diagram of normal person and central diabetic patients. In normal person, posterior pituitary sends a hormone ADH to kidney to help the control how much urine is synthesized. And in central diabetic patients, posterior pituitary does not make enough ADH. The kidney make a lot of urine. Diagnosis. In diagnosis, water deprivation test. In this test, to check if the body can concentrate urine. MRI of the brain for assess pituitary and hypothalamus. Third one is ADH level in the blood, and fourth one is serum and urine osmolality test. Central diabetic treatment. Central diabetic insipidus is treated by the administration of synthetic analog of ADH, that is desmopressin, which acts on photoreceptors of the kidney, which is responsible to increase water permeability of the late tubule and collecting tubules. Desmopressin can be given by injection, nasal spray, and orally in the form of tablets. It is also treating underlying causes. If tumor or brain injury is responsible to addressing the root of these causes, and it may help to detect the CDI. It can be also treated by the hydration management. Now, Next will continue by Shivani.
My name is Shivani, roll number 74. I will be representing nephrogenic diabetes insipidus. NDI is a rare disorder characterized by kidneys inability to concentrate urine leading to excessive urination, polyuria, and thirst polypsy. Unlike central diabetes insipidus, where the issue lies within the production of the antidiuretic hormone (ADH), NDI occurs when the kidney do not respond to ADH product causes. Genetic, the most common cause, especially in males, is a mutation in ABPR2 gene which encodes the vasopressin receptor in the kidneys. Acquired. This can be due to certain medications, that is leukemia, kidney disease, hypercalcemia, or the condition that affect kidney functions. Symptoms: excessive thirst and drinking large amount of water, frequent urination, dehydration, which can lead to fatigue, dizziness, and confusion if not managed properly. Diagnosis: water deprivation test to check the kidney's ability to concentrate urine. ADH levels can be measured and response to desmopressin, a synthetic ADH, can help distinguish between central and nephrogenic diabetes insipidus. Genetic testing to identify mutation in ABPR2 gene or X-linked ADH. Treatment: hydration, drinking enough water to prevent dehydration is crucial. Medication: thiazide diuretics, that is hydrochlorothiazide, may help reduce urine volume. Non-steroidal and lymphodepletions and SEIDs like indomethacin can also be used to help concentrate urine. Low salt, low gluten diet. Management focus on symptoms control as there is no cure for NDI. Further will be continued by Nikhil.
Good afternoon everyone, my name is Nikhil. I will be explaining SIAD, which is Syndrome of Inappropriate Antidiuresis. What is SIAD? In 1957, Swartz and Huth described the syndrome of inappropriate secretion of antidiuretic hormone. Recently, it has been observed that not all the affected patients had elevated blood levels of ADH, and therefore the term syndrome of inappropriate antidiuresis has been proposed. SIAD is a syndrome of sodium and water imbalance manifested by hypotonic hyponatremia and impaired urinary dilution. Causes of SIAD: endogenous causes. First is ADH secretion being increased from the hypothalamus. Second, ADH from ectopic production such as carcinoma. Third, drugs that potentiate ADH effect. Exogenous causes. Exogenous causes include administration of ADH and or analogues such as desmopressins, and idiopathic causes which are unknown causes. Diagnosis: decrease in effective plasma osmolarity, increase in urinary osmolarity, increase in urinary sodium, clinical euvolemia, normal thyroid and adrenal functions, and no history of recent use of diuretic agents. Supplemental features of SID: reduced serum uric acid levels, reduced blood urea nitrogen, fractional sodium excretion, fractional urea excretion, elevation of ADH levels in plasma even in presence of hypotonicity, and clinical euvolemia is another feature that may be seen. Management of SID. Management of this condition includes ruling out and addressing all the correctable causes, like correcting hyponatremia, restricting fluid intake, encouraging dietary intake of sodium and protein, administrating vasopressin receptor antagonists if hyponatremia persists. Thank you. Now, Ruchita will take over.
Good afternoon, everyone. Myself Ruchita. Now I will be explaining you about oxytocin disorder, autism spectrum disorder. The oxytocin receptor gene is associated with autism spectrum disorder. Oxytocin receptor gene has been studied as a risk factor for autism spectrum disorder owing to converging evidence from multiple levels of analysis. that oxytocin has an important role in regulation of affiliative behavior and social bonding in both non-human and humans. Inconsistency in the effect size of OXTR variants render it unclear whether OXTR is truly associated with ASD, and if so, which OXTR single nucleotide polymorphins are associated. Now let's discuss the symptoms of autism spectrum disorder. First, motor difficulties. Second, communication difficulties. Third, sensitivity to change and stimulation. Fourth, repetitive behavior. Fifth, social impediments. Now, Gayatri will explain the further topic.
Good afternoon everyone. My name is Gayatri, roll number 64. My topic is oxytocin related diseases. First is anxiety and depression. Oxytocin is negatively correlated with anxiety and depressive symptoms, and some studies propose it is used in treatment of this disorder. Post-traumatic stress syndrome. Oxytocin may play a role in pathogenesis and treatment of stress-related neuropsychiatric disorder like post-traumatic stress syndrome. Treatment for post-traumatic stress syndrome are physical exercise, group environment can be helpful, meditation, mindfulness, yoga, improve sleep. Third is lactation failure. Lack of oxytocin prevent milk ejection reflex and make breastfeeding difficult. Now Bhumika will continue further.
So that was all from our side. We tried our best to explain posterior pituitary in our words, although the content was taken from Guyton, Ganong and Harrison. I would first of all like to thank Dr.Santosh sir for his wonderful guidance while preparing for this presentation. I would like to thank our HOD Dr. Ruth Joshi madam for providing us with this wonderful opportunity to explain this very topic and getting a grasp of it. I would also like to thank the entire physiology faculty for making this happen. And lastly, I would like to thank everyone for being an amazing audience. And I would also like to thank and congratulate my teammates, because as the entire class almost knows about our PPT course, I hoped that it wouldn't follow us this time, but it did. And my teammates did a wonderful job handling it, and yeah, thank you.